I think it's all there, right? I mean, we're throwing a lot at you today, but the curriculum is actually pretty tight. You know, there's about 10 different core concepts to this, and we can show you that slide from the CDC or table of contents. So the curriculum, I don't think, is a problem. I think convincing a dean that it's important to fund this is the problem, right? So funding comes from all sorts of places, as you just said, but it's ultimately the unless you can find outside funding, you're going to have to convince your institution that it's worthwhile. I think there's a case to be made where you can say, look, these are the health impacts. Here's and it's not just us. It's it's Lancet, and very respected, funded scientists are saying this will become a big health crisis. And it's important for students to understand this, just like they would smoking, obesity, or heart disease. It's the same stuff. And if you don't teach it in med school, another thing, the students, they love it. They want to learn it. The students aren't the problem, right? It's us. It's the dinosaurs. Present company excluded.
I think one of the things that I came across, I was working on some educational materials for NIH, and I reviewed all the AAMC and the American accreditation for residency programs. And you look at the competencies that they expect medical students and residents to know. And embedded in those is things like population health, so understanding epidemiology, understanding the environmental aspects of what determines health. And a second aspect is looking at social determinants of health. And as Jay was mentioning, climate change is a disease of vulnerability. And I think you can make the case to say that there's a huge focus on looking at socioeconomic vulnerabilities, psychosocial vulnerabilities, and say climate change is a type of vulnerability. And so I think, honestly, it's not about reconstructing an entire medical school curriculum. It's about looking at content, and then how do you sort of bring the content into the structure, which actually already, people really thought this throughout. It's like, they thought this is important for doctors to know. We should know epidemiology. We should know what's happening around in our environment. So it's about getting content. And I think that, but you brought up that point, which is that, so who's going to teach this content, right? Because, of course, when we went to Colorado, there's people that teach these courses. And so then how do you get enough assistant professors? We need one, essentially, at every medical school to teach this. And so then how do you sort of duplicate? How do you get this to be bigger? And I think the textbook helps that, because it gives a curriculum, it gives a resource, and then it's about how do you train younger physicians to fill those assistant professor roles, to feel like they have some expertise to be able to run a course. But you're right. I think we're sort of at a point where we can sort of break through the next level in terms of having enough physician-level experts within academic institutions to be able to share knowledge.
I think we're going to talk a little later about kind of what are next steps and how do we proceed, but I envision a step where it's as CC is saying, it's impractical. We have well over 100 medical schools around the country, and we can't have people well versed and comfortable in speaking about climate change at all of them today. But what we can do is distance learning and webinars and providing those kinds of resources to schools and students to seek out, and that gets a little bit more of an economy of scale. And I'd also add that something Renee and I have talked about is that certainly at the resident level, but likely at the student level as well, we are teaching all of the things that we would want to be. We just need to put a little lens in it. So every residency program in their didactics has to teach how to manage heart failure. You throw in 3 minutes on, did you think about maybe environmental effects contributing to this exacerbation? And do the same thing with each disease process as we're doing it anyway. And everybody we should get to a point where every faculty member is comfortable just throwing that in without necessarily getting into the science of climate change. It's more, look, here are some causes, the epidemiology, the population health. Think about that, and it gets a little bit more embedded.
My alma mater is a problem-based learning curriculum, so the Cleveland Clinic Learner College. And so I actually engaged with them kind of end of last year. And so what they're trying to do is they're just for those, I think most people are probably familiar with a PBL case or problem-based learning case, there's sort of a list of objectives that they hope the learner will come out of after reading through the case. And so they're just trying to add one particular learning objective that has to do with like climate change and or an environmental health topic. And so it's a small lift in regards to really just adding one small component to cases that already exist, but it's just way, to kind of highlight what my colleagues here have already said. It's just adding that additional lens in, and I think overall administration realizes that's a much smaller ask than trying to incorporate a whole new topic. Thanks.
Come up to the mic here. I recently gave a talk on climate change and health to an undergrad course at USC, and have been asked to bring that talk to our residency, like at our grand rounds. I don't know how grand rounds are structured at your respective institutions, but ours are 4 hours, and attention spans are already stretched kind of thin amongst an ADD crowd of EM residents. And I'm just wondering what your thoughts were on how to take like my kind of mile-high overview talk that I gave to the undergrads and distill that down in what would be maybe more relevant to a residency crowd. I'm having trouble taking a step back myself because I find it all interesting, so I don't know like what topics I should maybe focus on at a residency level for an upcoming talk. And I mean, this is going to be like a half-hour talk at most, so.
I actually gave a talk when I was in residency to residents. I can share it with you. But I was like sort of what Renee was saying. You're looking at sort of heart failure patients, right? And they're coming in, and you're like, wow, why is this person? Why is their disease exacerbated? You always want to figure out the why. We treat the what, but why? And then could you consider that this patient's syncope because they're on diuretics, they're on beta blockers, and it was 100 degrees out for 3 days straight. It was their medications interacting with the environment that led to their presentation. And so sort of giving vignettes of how, how climate-sensitive diseases present in the emergency room to help kind of help people think about it. Mm-hmm.
I'll step out of my role as moderator and
yeah.
respond.
That's
I
good.
faced
No, you
that
should
same
be.
dilemma about a year ago or so, and I had to deliver a grand rounds to our residents. And it seemed to me that one of the challenges that our residents are going to face around this is recognizing unfamiliar dynamics that they haven't learned about, or potentially unfamiliar diseases, because they're practicing in a place that they haven't seen something. And so I went through a series of cases that I consider to be vanguard new presentations of diseases in new parts of the country that were driven by climate change. And so I tested them on the cases. Can they recognize the tertiary complications of lung disease, et cetera? But also illustrated a larger point around the dynamics and evolution of diseases and what they can expect going forward. So I'm happy to share it with you. But cases are always a good way to engage people.
Yeah, that's the point I was going to stress, is to make it clinically relevant. And I think that we're at a point where we're really trying to get data around that to support how it's impacting our clinical practices. But again, like honing that how they can actually take that information and use it on their next shift.
And I would say to also include solutions. I think it's wonderful to have the clinical knowledge, but I think we want to be educating and inspiring people to take action. We want them to be climate leaders, and that's going to mean different things for different people. But I would think in any presentation, the ones I give them tools and solutions, because as I think Ted brought up or someone brought up, a lot of people feel very hopeless, like there's this doom and gloom, like what am I supposed to do about it? So I would encourage you to include, solutions and action items, which I'd be happy to share with you.
Yes, sir.
Yes, I want to say again, so I can't give you more about the social determinants of health. I think that's an issue that I think is front and foremost now in a lot of our minds and how to deal with that. And it's kind of quite a term called never discharge, right? From the ED from the hospital. So we think about never discharging our patients in emergency medicine. I think we in the past have been very guilty of that, right? So, okay, they leave the emergency room, that's it. We don't really care what happens to them afterwards. The follow-up in primary
Yeah, I mean, I think you talk about thresholds, but I think we talk about threat multipliers, right? So, well, 400, is that different than 410? Okay, maybe not, but here's what's gonna happen, and here's what's gonna happen to the weather, into our biosphere, and here's what's gonna happen to human health. I think the right messaging is we're going to be seeing a lot more of this, these diseases, because they're being driven by these other effects. And the people that are going to be suffering the most are the most vulnerable. So I think that falls squarely within not only medical school curriculum, but emergency medicine training as well.
I was going to ask a question about communicating uncertainty and the fact that a lot of the projections have a wide area of probability, and also the fact that we may be in a climate atmosphere with CO2 levels that we haven't actually seen before, and so we may not actually know what that looks like for this planet, and if you found ways to effectively communicate that to either medical students or other audiences.
I'll put my engineer hat on. There are a series of large fluid dynamic models that are used, so you're right, we don't exactly know what the atmosphere is going to do when we hit whatever threshold we hit, but we have probably between a half a dozen and a dozen fairly robust, accurate, different large-scale mixing models that I think give a pretty good prediction with ranges. As we get when we look at microcosms as well. My way of communicating that is kind of twofold. There's a little bit of a Pascal wager that if I'm wrong and we do something anyway, then all we've lost is some effort in doing something. But if I'm wrong and we don't do something, then the consequences could be quite significant. So I would describe using the best available information. We do that clinically all the time. We treat patients based on the best available information as it becomes available. And sometimes we're right and sometimes we're not. This is the same thing here, where the best available information points in a consistent direction. Whether we might be off by a little bit on the margins, I don't think is terribly important. I also advocate not really. We talked last week at the Clean Med conference a little bit about advocacy and the basic premise, the basic statement when you're trying to advocate on behalf of this field, and somebody asks you a question that is more challenging to answer. So say you're meeting with some decision maker and you want them to do whatever, and they ask you a question. Well, the science isn't settled. The first step is not to accept the premise of the question. That I'm not going to debate the specific science because the science isn't debatable. The models are good. The outcomes, there are error bars, but there are error bars in everything we do. So I would say we describe it honestly and openly and leave it at that. So I hope that answers.
I'd go the opposite side in complementary, not in opposition. But
wouldn't be the first
put
time
on
Stuart
the
disagreed.
humanist hat as opposed to the scientist hat. And I think one of the geniuses of medicine as the most human of the sciences is that every day we take discrete scientific information and put it into an actionable story that influences our patients. And Ms. Smith doesn't give a damn if her sodium's 128 or 1. It's like there isn't a baseline that, you've crossed this threshold. But it's saying, if it's a patient with diabetes, if you want to be able to walk down the aisle with your daughter in X years, you want to get your sugar under control. This is why your A1C matters. It doesn't matter what the number is, but the risk of you having a bad outcome and not being able to get to where you want to go by not taking an action now, kind of like Jonathan's Pascal's wager, it's like it's a limited investment and a huge downside if you're wrong. And I think that's something we're really good at and something we should embrace and kind of run with.
I couldn't take the humanist approach because I'm an engineer.
I've seen him.
the stat out the last week.
I was going to say one last thing. So Gina McCarthy, she's the former director of the EPA. She just joined the Harvard School of Public Health in January. And she just gave, I don't know if anyone's heard her speak, but I mean, she's like a rousing individual. And so she actually recently just spoke at the Boston University for a one-day seminar. And she literally said, stop hedging. She's like, no one's going to follow someone who's hedging. And she said, scientists are the only people in the world who have such robust evidence, and they still hedge because there's a 1 or 2% or 3% or there's a larger error bar. So she said, if you want to lead and you want people to follow you, just stand true in what we know now and move forward. And so obviously I quote her on that, but I think that that's a true thing to stand on that as we move forward.
And similarly, just say the Woods Hole Research Group again, they're hardcore freaking scientists. When I'm around them, I'm like, I fall down at their feet. But their adoption of a narrative approach is something they're having somebody come in to speak to the board this week about, how do you tell the story? How do you influence the narrative and affect change? So we've got the data. We need to act on it. We don't need another A1C to see that things are, well, maybe it's not a good.
All right. We have time for one quick?
Yeah, sure.
It may not be a quick question, though.
No, that's all right. Yeah.
Might be a quick question. Is the answer going to be quick?
So there's multiple components. The first one is, as Dr. Hess brought out, as far as strategies go, every region has their own problem. From down in Texas, heat waves and mosquitoes are really big. And then other places have hurricanes that are really big. So what is, have you ever thought about reaching out to directors, or how has it been with reaching out to program directors or associate program directors and seeing if they are receptive to implementing climate change topics into their education strategies and addressing their specific needs? So if you were to reach out to someone in the Southwest, you talk to them about mosquitoes and hurricanes and how that's a big thing, and how climate change being integrated into their curriculum if it's addressing certain emergency medicine topics. I guess in general, how's the reception been with you reaching out to associate directors or program directors?
Interest group. The SAEM interest group.
Oh, to use on the platform, yes. So the SAM interest group is put forth as a platform with which to do that. In which case, you should come to our interest group meeting that we're going to be having, plug now, on Friday at 10 a.m. And perhaps we can have medical student and resident involvement in leading that forward. So I agree. I mean, I think it's a great platform that needs to be done. Sort of that, great ideas need leaders. So I think someone should lead that.
Yeah, I mean, there's definitely a regional desire, from talking to different leaders, that they were like, well, how do we make it relevant in our state or our region, for sure. To the specifics of your question, I'm not sure that this, we've gotten to the point where we're now engaging with residency leadership. I don't think we're quite there yet.
But that approach is being taken. So the NCA4, the National Climate Assessment, the 4th edition, is all based on regions, right? So they basically broke the country to 8 regions and said, we need to look about the impacts in these regions so people can, mobilize around those specific issues. So I think that's really important.
And I know discussions that we've had is to create a core set of education slides, but I think the important piece in doing that, because while there's some that's applicable to the entire country, we need, to your point, we need some that are region specific.
And we'd be happy to come and visit.
Especially nice places.
But I think to add on to your point, the one way that things get disseminated in our community is through grand rounds speeches. And to some degree, the topics for those are generated from the bottom up, from residents and other folks at a local institution who say, I'm really interested in hearing more about this, or I think this person is a good speaker. Consider bringing them out. And that advances people trying to develop a niche in this field because it supports their education building, which is important for their career development, but also gets the word in significant platforms. So, related to the point you made. All right. Join me in thanking our panel.